anyways, and then you're going to see what I mean. It's something a lot more comfortable than what you were doing with OA, posterior and anterior. So on page 196, I'm going to do the assessment of AA. Again, it's pretty straightforward. There it is. So, I can either do it on this model, of course, but I'll demonstrate it first, and then I'll have somebody come down so you can see how it really looks when you're working with a person. The articulation that I'm looking for here is this articulation, C1 and C2, okay? Rotation. So what I'm going to be doing is I'm going to be assessing that mobility. What I'm going to do to help prevent rotation from then occurring at the lower cervical spine is I'm actually going to flex the neck up. I'm going to flex it up to about a degree. Actually, he says sometimes full flexion, and then in the treatment section, for some reason, he says about 45 degrees. If you want to take them up into full flexion, that's fine. Okay? And you're going to make contact with the occiput. You're also going to cradle around the posterior arches of C1. I like doing it that way. He demonstrates it just holding the side of the head. And when I mean he, of course, Phil Greenman. So you're flexing them up, and the reason why we do the flexion is that it forces a locking mechanism to occur in the lower cervical spine, not only with the joints, and I mean the anterior joints of von Luschka, but also the tightening of the ligamentous structures. So you get an inherent locking mechanism by bringing them up into that full flexion position. And at that point, we're in their full flexion position. What you want to do is you want to rotate their head around an axis. It would be horrible to see you do rotation with side bending. It actually has to go along the axis of rotation of the dens. So you really want to be specific in just going around that axis. You can actually create an imaginary axis for yourself of rotation through the vertex of their head right down to the table. And don't veer from that line. Just make it freely spin around that axis. And what you're going to do in doing so is you're going to assess C1's ability to rotate to the left and feel for the end field. Bring it back to neutral, stabilize, and now rotate C1 to the right, checking again for excursion, end field, and quantity and quality, just like always. All right? Let me have somebody up here. We'll put the camera down at the table. And I'll show you how easy this is to really do. Someone come down, please. Yeah, sure. Thanks, Dr.
You want to go? You have a tight neck?
So we're in the flex position, so we don't have to really worry about the vertebral, the arterial system so much. Really more of a problem if we're going into extension for the occlusion. So what I like to do, just have it here. Contact the occiput. Slip just inferior to the occiput, so I know I'm on C1. Okay? Because that's the only thing that's underneath the occiput is C1. Thank God, that's why we know them that way. And then what I'm going to do is I'm going to flex the head up as far as it can go. Definitely past, at least to 45 now. And you can see that I'm cradling the head side. Don't do a pec squeeze and crush your patient's head when you do this. I also have another contact I've chosen to get involved with in just a little bit of my belly, so that I can make a contact with the head and the head feels more supportive. Always helpful the patient relaxes during this motion. You can see my elbows out to the side. Now, looking at that imaginary axis running right through the vertex of the head, I'm now going to assess for AA's ability, or C1's ability to rotate to the left. He's doing pretty well because I want to see at least about 45 degrees. Okay? Come back to midline. Going to assess it again. Maybe give a little spring just to see how that end field reacts. I feel that it's firm. just as we would expect, like a capsule. Then come back to midline. Oh, we definitely have a little rotation restriction that way.
I do? Yeah. It's
Yeah, you
right.
do. AA going to the right is definitely restricted.
Yeah.
Relax. And right there. You could almost see. I'll go back to neutral. Watch how much of Dr. Doris's face is exposed to the camera when I go to the left. Come back to neutral. On C1 on the left side. Can anyone see that difference in the... You can see it. You can feel it, and you can definitely see it. That's your assessment of AA. Now, if you're limited in right rotation, you have a positional fixation of being left rotated. If you have a limitation in left rotation, you have a positional fixation at AA as being right rotated. Okay? And you can document it as such. So, let's break into lab and do that assessment.